Hi, folks. This is the recorded lecture for the third and final cardiovascular lecture. It's going to be the end of it for 12.8 through 12.19. And we're going to do 12.8, 12.9, 12.10 pretty consecutively. And then we're going to skip around a lot through that last part of cardiovascular. And as I've said before, I'm not even going to do any of the cardiomyopathies. Unfortunately, even though they're super cool, we don't really have the time to get to those. So we're going to be skipping around in the end part of the chapter. So just make sure that you're following the notes as you go to study. And don't worry about the sections that we do not cover in this lecture for the quiz this weekend and for the exam. Okay, I'm going to share my screen. And the revised lecture is on Connect. So if you have previously downloaded this lecture, make sure you go and find the updated one, the one that says either updated or SP21, so that you make sure that you are getting the notes that have these updated slides in them. So we left off last time with arterioles. Just kind of an overview. The first part of this lecture, if you remember, was an overview of the vessels and the larger vessels in the arterial system. And now we're getting down to the arterioles, which are the smaller vessels that are right before we lead into the capillary system. And this is where we have a lot of ability to regulate that inner diameter of the arterial system in the arterial region. So the bigger vessels are going to do a lot of helping propel the blood into these smaller arterioles through their elastic capacities that they have. So we talked about capacitance and how the rebound, that elastic recoil, helps force the blood into these smaller vessels in the arterial system. And then at the level of the arterioles, we have a lot of ability to regulate whether the tissue that they feed gets a lot of blood or doesn't get as much blood. And as we talked about, this is due to smooth muscle contraction or relaxation in the walls of the arteries. So the outer connective tissue has been removed from this diagram to show you that we have endothelial cells that are lining the inside of the vessel. And then right around that, in that tunica media, the middle tunic, the middle shroud of that vessel, is a whole bunch of smooth muscle. And it's going to be way more packed and tighter and continuous than they're showing you here. But they're trying to make it really clear that there is an endothelial layer of an epithelium on the inside of the vessel. That's that slick endothelium that reduces friction and lets the blood flow. And then we have that smooth muscle layer. And this is the layer that is going to either constrict and lower that inner diameter or relax and let the blood push it open more. And then that layer, like I said, that's not shown is that outer connective tissue layer that is going to wrap the entire blood vessel and make it strong and have good resistance to make, just make the entire tube. So we're going to focus a lot in this next section on these smooth muscles and what can make them either contract or relax. And as we talked about in the smooth muscles section of chapter 9, there's a lot of things that can change whether we're contracting or relaxing in a smooth muscle. So they are neurally controlled, they are hormonally controlled, and they have a lot of local signals that can also change whether they're contracting or relaxing. And this ability to contract and relax allows a minute by minute control of the blood pressure in that area and the flow, importantly. So if we constrict, we are going to divert blood flow away from a tissue. And if we dilate, we're going to let it in. And remember what we've talked about with that major change in fight or flight. So I just ate breakfast a couple hours ago, and because I did that and I am in a non-stressed state, I have a lot of blood going to my digestive tract right now. My liver, all of the main organs and all of the accessory organs, all the way from salivary glands, esophagus, probably not as much going on in the esophagus right now, stomach, but small intestines, liver, gallbladder, all these are getting a lot of blood flow. So I'm going to have vasodilation in the arterioles that are leading to these organs. Whereas I'm going to shunt blood away from my muscles because I'm not doing any big muscular activity right now. So I'm going to vasoconstrict in the arterioles that are leading to my muscles. So I give more blood to the core of my body and in particular into my digestive tract. Now, if I were to decide to go for a run, that would flip and I would vasoconstrict in my core area, especially in the digestive tract area, and I would vasodilate in my muscular arterioles, allowing lots of blood flow to go out to those muscles. So remember, flow is a change in the pressure from one spot to the next over the resistance in that tube. And so your book sets up this kind of visual to give you an idea of what's happening across the body. Say you have a pressure reservoir, and that's going to be your larger arteries that are sending blood into these arterioles. And then these little outflows are going to be your arterioles. And then whether it's fully open or vasoconstricted is going to determine the flow. Remember, if we have more vasoconstriction, we have more resistance and our flow will decrease because the flow is going to be inversely proportional to the resistance. So more resistance, less flow, less overall volume of blood would get to that organ. If we have fully vasodilated, low resistance vessels, we're going to have lots of blood go into them. And so the flow is going to be high, the volume is going to be high. And then just a different set of circumstances where you are regulating these arterioles differently, you can very quickly and greatly change the amount of blood going to a particular tissue, say 3, which was having almost no blood go to it because of vasoconstriction in scenario A. And now in scenario B, with full vasodilation, it's getting lots of blood. So good to kind of understand this diagrammatically like we're showing here, but then also make sure to relay it onto the body and what we know about that fight or flight system as we're kind of going here and the switch between parasympathetic and sympathetic whole body activation. So let's talk about that. How do we actually get the sympathetic nervous system regulating that blood vessel diameter? And it is almost exclusively the sympathetic nervous system that regulates blood vessel diameter. There are a few cases that we're not even going to talk about because they are so limited, rare, and largely inconsequential, where parasympathetic nervous system can regulate blood vessels. But we're not, like I said, we're not going to talk about it because overall, there's really just no parasympathetic nervous system effects on blood vessels. You'll have to get like way into your cardiovascular residency to talk about that. Probably you're probably not even going to really talk about it in med school if you go to med school or vet school or nursing. But you will talk about this because a lot of our drugs are beta blockers or they're alpha adrenergic blockers, or they are agonists for these. So lots and lots of our drugs are going to have effects on the sympathetic nervous system receptors on blood vessels. So you definitely need to know these that we're going to talk about on this page. So sympathetic nervous system activation is going to affect your blood vessel diameter. And it depends on the receptors that are on the tissue. So if you have an alpha receptor on your blood vessel, and you get something like either norepi coming directly from the sympathetic nerves, or you get epinephrine that's been released from the adrenal medulla. Remember, both bind both. When it binds, either of these neurotransmitters, neurohormones binds, you're going to get vasoconstriction. And your two different receptor subtypes are going to actually activate two different two different second messenger cascades. Alpha 1 binding activates the IP3 pathway. So we're going to get release of calcium from the endoplasmic reticulum in the smooth muscles, as we talked about in chapter 5. That's going to lead to a lot more calcium being in the cytosol. More calcium means more calcium calmodulin, more activation of MLCK, more cross-bridging, more force. Okay? The other thing you can do is you can have them bind to alpha 2 receptors. And when they bind to alpha 2 receptors, what you're going to get is you're actually going to get a decrease of cyclic AMP. And cyclic AMP is an inhibitor of MLCK. So we have a break. With cyclic AMP, we can have a break on cross-bridging in smooth muscle. And what we're doing is we're lifting that break off. So we have less inhibition. And therefore, we're going to get more constriction. And a lot of times you have a subpopulation that has both of these receptor subtypes on the arteriole. If we bind to a beta adrenergic receptor, like down here, again, either epi or norepi, but mostly we're going to have an epinephrine effect here. This is going to increase the amount of cyclic AMP. So we're applying more of a brake. Cyclic AMP inhibits more MLCK, leading to less cross-bridging, leading to less force. And so we're going to inhibit that contraction, and the blood itself is going to force that vessel open and give you the dilation. So overall, we can get the release of norepi from sympathetic nerves, or we can get the release of epinephrine from the adrenal medulla due to a sympathetic effect. Norepinephrine in the extracellular fluid is going to bind to alpha adrenergic receptors and going to lead to vasoconstriction through the two mechanisms I suggested. Plasma epinephrine can bind both alpha adrenergic receptors and lead to vasoconstriction as well, or it can bind to beta adrenergic receptors and it can cause vasodilation through the mechanisms we talked about. And remember, I often put things in the notes down here. I actually need to go in and I will get you the reference. So whenever I pull things from other sources, papers or other sources, I usually list them in the notes down there. So if you're like, this isn't in the book, because for whatever reason, even though the book teaches you about these mechanisms, they decided to not put them in there. And you know how I love my mechanisms. So I went and dug them out. And just whenever you're like, this isn't in the book, I usually have references in the notes to where you can find more information. So the sympathetic nervous system produces what we call the overall vasomotor tone. And it's regulated primarily by those alpha receptors. So if you get more action potentials through more sympathetic nerves, you're going to get more norepi, you're going to get more vasoconstriction. If you get fewer action potentials, you're going to get less activation, less constriction, and then the blood itself pushes open the vessel. So you can see the tonic control generally is going to give you action potentials down those sympathetic motor neurons, and you're going to get an overall tone, right? You're going to get an overall medium level of vasoconstriction, which is going to help with blood pressure. If you need higher pressure, you're going to vasoconstrict, so you're going to send more action potentials down those sympathetic nerves. If you need more flow, less pressure, you're going to send fewer action potentials. The blood's going to force open the vessel, and you're going to get vasodilation, and you're going to get more flow. We can also have local regulations. So that big systemic regulation, the things that are going to happen all over the body all at once, is going to be through the autonomic nervous system. And again, through those two pathways, either sympathetic neurons releasing norepi, or through sympathetic neurons causing the release of epinephrine from the adrenal medulla, which goes through the bloodstream, which goes everywhere. Okay? But on the local level, you can also get regulation of the smooth muscle right there on the tissues, on the smooth muscle that's right there in that area. So the endothelial cells themselves secrete paracrine agents that then go through the interstitial fluid and are going to be bound to receptors on the surface of the smooth muscle cells that are right there next to them. So you can induce relaxation or contraction of an adjacent smooth muscle by the endothelium basically telling the smooth muscle what to do, or the smooth muscle itself being regulated. So we've got two types of local regulation. We've got active hyperemia and we've got flow autoregulation. And we're going to break these down in the next two slides and talk about them. So active hyperemia is when you get blood vessel dilation, arterial dilation, leading to a capillary bed of a tissue that is active, that's metabolically active. It is doing stuff and it needs more blood to feed that tissue. So the increased metabolic activity of an underlying tissue gives you signals that are picked up by the smooth muscle leading to that capillary bed. And you're going to get more vasodilation. So you're going to get inhibition of contraction, more vasodilation, more blood flow through that capillary bed to help feed that tissue what it needs. So the metabolites cause vasodilation, which is going to give you an oxygen demand that matches oxygen supply, or the supply matches the demand. You get this a lot when we exercise. So as the muscles start producing lactic acid and CO2 and start reducing the amount of oxygen in the adjacent area, these are all of the types of signals that are going to be picked up by the smooth muscle, and it's going to lead to inhibition of contraction. So then you get dilation of the arteriole, more blood flow because of less resistance, and then more blood is going to take out the lactic acid. It's going to bring in more oxygen. It's going to take out the CO2. And then as that situation resolves, like as you continue to use the muscle, you'll continue to produce these signals. You'll continue to vasodilate. But as you stop exercising and the situation resolves, you get fewer metabolites, you get a higher stock of O2, and then you will reduce this inhibition. And you'll get a more normal situation returning again. You also have this in cardiac muscle, of course, because we need to feed the muscle of the heart to help it pump the blood. And then you can have it in glands. So glands that are undergoing a lot of activity at the time will need more blood to help, again, bring out waste products, maybe actually move the secretions of the gland, and then help support the metabolic activity of that tissue. Flow autoregulation is really about, again, supplying the tissue with the amount of blood that it needs, but it's also really about keeping the blood pressure regulated appropriately for a given tissue. You see this in the brain a lot. And this figure that I've given you, again, not in your book, I've got the reference below, is for the brain, what we're doing in the brain. And it makes a lot of sense that the flow of blood needs to be pretty consistent in the brain across a range of blood pressures, right? Too high a blood pressure in the brain is going to lead to potential stroke, right? We don't want that. And too low a blood pressure in the brain doesn't actually get what it needs to feed the neurons, and you will pass out. That's why if you ever occlude this carotid artery on both sides with like a chokehold, it takes seconds before people pass out. I saw this guy one time on one of these, kind of early day reality shows, kind of doing the science behind it. And he let an MMA fighter choke him out. He was very nervous about it. The MMA fighter knew how to do it safely to preserve like windpipe. And it took about 4 seconds for him to pass out. So it doesn't take long having insufficient blood pressure to pass out, and having too high a blood pressure in the brain could be incredibly damaging, leading to stroke and death. So you've got a lot of flow autoregulation in the brain, and then you also have it in other tissues as well. So this is giving you a situation where the arterial pressure is too low and your blood flow to the organ is too low. And again, the signals often come from the fact that we're not having enough oxygen, metabolites are going to increase, and then you don't have enough stretch in the wall of the organ. So stretch is a factor in flow autoregulation that it isn't in hyperactive hyperemia. When you get that decrease in stretch and you get these buildup of metabolites and loss of O2, you'll get dilation, which will restore the blood flow, and then you'll be able to keep it and the appropriate pressure. But the opposite will actually also happen as well. So you can see here, super, super low blood pressures, the vessel is going to dilate more and more and more to try to get more blood to the tissue. And if you have super low blood pressures, sometimes you still can't get enough flow. The artery could collapse and you get ischemia, which is not enough blood flow to the tissue, and you can get tissue damage. But then within a huge range of blood pressures, from 50 millimeters of mercury, which is super, super low for most people, a systolic pressure of 50 is super low, all the way up to 150, which is definitely very high, you can have autoregulation that keeps the flow of the blood constant. So at lower blood pressures, you're going to have that more dilation. You're going to have signals that dilate it. And then as the blood pressure comes up, you actually have less of a signal. So you start to vasoconstrict more and more and more. And up until when you get to really high blood pressures, you're going to be constricting a lot. And all of this keeps the flow constant. So the amount of blood that's actually getting to the neural tissue stays the same across a huge range of blood pressures until you get super high. And then the force of the blood itself pushing on those vessel walls overcomes the ability of the muscles to push against it. So basically the muscles just cannot produce the amount of work that they need to overcome the force of the blood. And so this is called force-mediated dilation that increases the flow, and then you're going to get vasogenic edema. So basically the blood is just going to be pushing so hard against the walls, the contraction can't keep up, and you'll get leakage of fluid across the tissues. So if this were in the brain, this would be bad. It would cause encephalitis. And anywhere else in the body, if it's too high, you're going to get swelling in those tissues. Edema is swelling. But it is good across a huge range of blood pressures. So this is good to know as like an emergency practitioner as to when you're going to need to give something like epi or norepi at a very, very low blood pressure, or when you're going to need some sort of beta agonist when you're going to need some sort of other sort of regulator if you're getting blood pressures that are too high. Yeah, actually you need a beta 2 agonist so you can actually decrease heart rate and heart contractions. Okay, so let's talk about that mechanism of the myogenic response for a second. So this is a cross section of our microvessel, okay? And as the blood pressure starts forcing the walls of that vessel open a bit more, you're gonna stretch the membranes of the smooth muscle cells. And you have stretch receptors in there that are stretch sensitive ion channels. And this has sodium and calcium kind of going through one, but this is diagrammatic. It would be a sodium channel and a separate calcium channel. And then of course it would be thousands of these. But stretching both of them, of course, helps lead to positive ion influx. And the sodium is going to help with the depolarization that leads to the calcium influx. And of course, calcium is going to bind to calmodulin, which activates MLCK, which activates cross-bridging, which activates contraction. So both of these things are going to lead to more cross-bridging, more force. And what you can see is during a resting state, your vessel diameter is going to be at a small state, and the pressure is going to be low. But then, as you say, start exercising, and you're pushing more blood through that vessel, then the blood pressure is going to jump, and the stretch, that myogenic response, is going to be to counter with contraction and keep the flow the same so that the diameter comes back. So even though the blood pressure is going up, the diameter comes back down, so you keep the flow steady. It's a super cool response. It's a pretty simple mechanism that can work on this, again, second to second response time to immediately regulate the flow so that you don't get a massive amount of blood flow into a tissue. Or if it's too low, you get enough blood flow into the tissue and you keep the pressure high enough. So we have this one mechanism I'm going to talk about, which is a combination of a systemic and a local control. And that's nitric oxide neurons. And way back in the 618 lecture where we talked about the autonomic nervous system, I talked all about sympathetic neurons and parasympathetic neurons. And then there was this little sort of footnote. Oh, by the way, there's also some nitric oxide autonomic neurons. I'm not going to talk about them right now. I'll get to them later. This is the later. So there are a few neurons in the autonomic nervous system that are not sympathetic or parasympathetic. They are nitric oxide neurons. And you most often see them in the penis, the clitoris, and a lot of the GI tract. And so it's nitric oxide that is released from the end of the neuron that causes vasodilation. You can also have endothelial cells themselves that produce nitric oxide that can cause vasodilation. So this is the main mechanism for erection in the penis and the clitoris. So what you do is you, again, prevent contraction in these smooth muscles that are in the arterioles, leading to the capillary beds that feed these erectile tissues. And when you inhibit the contraction, you'll get the blood pushing the arteriole open, and you'll feed that tissue with blood. And then that blood gets trapped in there because you actually constrict on the venous end of it and you don't let it go out. And so then we're going to allow blood in and not let it go out for the period of sexual stimulation. And that is what is going to make the tissue become erect. So, like I said, Viagra, pretty much the most prescribed drug across the planet, makes billions of dollars every year. Let's talk about how that actually works. Okay, so first I'm going to walk you through the mechanism of how we get this mechanism happening. And then we're going to talk about how Viagra enhances that mechanism. All right, so we get sexual stimulation in either the penis or the clitoris, and that's going to cause action potentials in the cavernous neurons. It says cavernous nerve, but of course these are the neurons that are in the cavernous nerve. When the action potential reaches the axon terminal, you're going to release nitric oxide into the synaptic cleft. Nitric oxide is a gas that will diffuse through the membrane of the smooth muscle cell, where it's going to activate guanyl cyclase. Guanylyl cyclase takes GTP into cyclic GMP, and cyclic GMP is the second messenger that activates a whole bunch of stuff. Specifically, it activates cyclic GMP kinase, protein kinase, and the kinase, as kinases do, phosphorylates everything. As it's phosphorylating things, it causes the pumps in the endoplasmic reticulum to bring more calcium and sequester it. It causes the pumps on the plasma membrane to do more pumping and get calcium out of the cytosol. So again, we're taking calcium out in two ways, sequestering it in endoplasmic reticulum and kicking it out. It inhibits the calcium channels that we're letting calcium in. So no more calcium coming in, kicking calcium out, preventing it from coming in, sequestering it. All of this taking cytosolic calcium way, 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 way low. It also activates more release. It activates potassium channels. So we're going to get hyperpolarization of the smooth muscle membrane. So it's going to be less likely that you're going to get an action potential that would result in calcium release into the cytosol. So all of these mechanisms result in calcium in the cytosol going way, 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 way down. No calcium, no activation of MLCK, no cross-bridging, no force, and we get relaxation. To stop this, so let's say it's a natural erection that does not have any medication going on with it. When the sexual stimulus ends, the neurons will stop releasing nitric oxide, and this whole cascade of events will be stopped by phosphodiesterase 5, which will take cyclic GMP and turn it into just GMP5, 5' GMP. So it uncyclizes it. It's a cyclase. So it's going to uncyclize the molecule, and then no more cyclic GMP, no more activation of cyclic GMP protein kinase, and all of this stops. And so then you get a contraction again in that arteriole, and you stop feeding the tissue with blood. Consequently, you're going to get the venous system letting blood back out, and blood will go out of the erectile tissue, and the erectile tissue will go back to its normal resting state, a flaccid state, which again, remember, is important for keeping those parts out of the way and safe in a non-sexual activity state. So what Viagra does, so for folks that have trouble getting erections, and that should only be used by folks that have trouble getting erections, by the way, some people, get into this enhancement thing and think that it's a good idea. It's not. It's not, because you can really damage your penis. For folks who have trouble getting and maintaining erections, and it's usually folks who are older, because body function changes as you get older, taking Viagra can inhibit phosphodiesterase 5. So we take that out of the equation, and then the amount of nitric oxide, which was previously too low to maintain an erection, will now be enough, because you'll build up and maintain lots of cyclic GMP, promoting relaxation for an extended period of time, which then wears off. They've done the amount of the dose and the timing of the effect of Viagra to last no more than 4 hours. And again, if it lasts more than 4 hours, go to the ER. Like, not a doctor, don't wait for an appointment, go to the ER, because you need an antagonist to inhibit this effect, to make sure your blood vessels do not get damaged. Okay? So this is the mechanism that Viagra works on. It inhibits phosphodiesterase 5. We have an accumulation of cyclic GMP. We promote smooth muscle relaxation in those arterioles to the erectile tissue, specifically men. This works better on men for the amount of time that you want to sustain the erection, and then it will wear off, and then we'll go back to resting state. So just thought you should know the mechanism of action of the most prescribed drug in the world currently. And hint, hint, it might be a good idea to know the normal mechanism and then the drug interaction in this mechanism, the site of the drug action in this mechanism for the next exam. Okay, so now we're going to continue on through our vascular system. We've done large arteries, smaller arteries, arterioles, and now we're going to get into the capillary bed. Okay, so the capillary bed are the smallest blood vessels. And this is going to be the site of gas and nutrient exchange. And what you're going to get is you're going to get diffusion of the good stuff out of the blood vessels and into the surrounding tissues. And you're going to get the diffusion of bad stuff into the blood, and it's going to be taken to its various sites for dealing with the bad stuff: kidneys, liver, lungs for the gases. Okay? The endothelial cells in the capillary, so capillaries now are just endothelial cells. You can see it's just a couple of endothelial cells that are going to be fused. They're going to have clefts in between them, and they're going to be connected loosely with cellular junctions. You're going to have the cell stuff over kind of to one side. You can see here, this is where the nucleus and a lot of the organelles are residing. And then mostly the rest of the walls are just going to be plasma membrane with not a lot of organelles out there. And this is allowing for a very, very limited amount of cellular stuff in between the blood and the interstitial fluid, which makes diffusion very easy and very effective. And you can see an erythrocyte, the diameter of the erythrocyte is only just barely smaller than the diameter of the capillary bed. And this is, again, by design, by evolution, so that you maximize that diffusion capability. So pretty much oxygen is going to be offloaded to its maximum extent in the capillary bed. Carbon dioxide, as we're going to see in the next lecture, is going to be onloaded to the maximum extent. So diffusion is very effective in the capillary beds. When we talk about capillary networks, you see what you get is we've already gone from big vessels to smaller vessels to arterioles, and then capillary beds are just really lots and lots of very, very, very small diameter vessels. And because they are so numerous, our total cross-sectional area goes way up in capillaries. But also, because they're so numerous and then they are so small, our velocity, our flow goes way down in capillary beds, which again, by design, also really good for diffusion, right? We have a long passage and lots of connectivity between blood and vessel wall in those capillary beds, which allows for lots of connection, lots of diffusion, and slow movement through it. And this is analogous to a riffle zone in a river. So I don't know if you guys have ever come down to Austin and gone tubing, it's super fun. And when you go through a chute on your tube, you go fast. But then if you get into places where the riverbed widens out and gets real shallow, you go real slow on your tube. And so you can think of the same thing in your arteries, in your aorta and your large arteries. The flow is going to be fast, large diameter, lots of flow. And then as we get into that smaller riffle zone area, the flow slows down, but there's lots of pathways to go. Okay? And you could think about dumping a whole bunch of leaves in that river and kind of watching them go, right? They're going to go through that chute together and super fast. And then as they get into that riffle zone, they're going to spread out and go and meander slowly through the rocks. When we get on the other side of a capillary bed, we get into the venous system. So venules are going to be those small veins, and then we're going to lead into larger veins that are going to lead back to the heart. And remember, we talked briefly about their structure. They have smooth muscle, they can vasoconstrict, but it's a lot less than what you have in arteries. So they can't pressurize the blood near as much as arteries can. And they have a lot more elastin in the walls, so they're actually greater at expanding, and they have that greater capacitance. So large arteries, yes, they have capacitance, they have elastin, but they're a lot better at pressurizing the blood because they have a lot more muscle in them. And then large veins are actually better at expanding and holding a lot of blood. And they can vasoconstrict, but it's not to the degree that arteries can. So our venous system is where most of our blood is at any given minute in our body. And it acts as a blood reservoir. So greater than 60% of our blood is in our veins and our venules at any given time. Only less than 10% is in the heart. A little more than 10%, 12% is in the lungs and the pulmonary circulation. And only a little over 10% is in the arteries. And less than 10% is in the arterioles. So kind of divided amongst these other 4 big areas, lungs, heart, arteries, and arterioles and capillaries is where your other 40% lies. And most of the blood, over 60%, is in the veins. It's very low blood pressure in the veins, less than 15 millimeters of mercury, around 15 millimeters of mercury, which remember, in the arterial system, like your systolic pressure is normally around 100. So way differences in pressures in the 2 parts of the systemic circuit. The ways that we can modify venous pressure, there are 4 different ways: sympathetic nervous system activity, blood volume, muscular pumps, and respiratory pump. And we're going to talk about each of those. So the sympathetic activity is the exact same as it is in the arterial system. You're going to get action potentials down sympathetic neurons, release of norepi onto alpha-1 or alpha-2 receptors, working through the same mechanisms that I told you about in the arterioles. More action potentials leads to more constriction, leads to greater amount of pressure, more resistance, less flow through the vessel, and a lower rate of sympathetic activation leads to less constriction, more relaxation. The blood's going to push through, vasodilate that vessel, and you're going to get more flow. The blood volume. Normal amount of blood volume and a normal diameter of your vessel is going to lead to a normal blood pressure, or that very low blood pressure that we're talking about. But say you drink a ton of water in a shorter period of time, not recommended. You can actually get yourself a condition called hyponatremia, where you can damage yourself by drinking too much water. It's hard. It's very hard to do. But there was this contest a long time ago called Wee for a Wee radio contest. People tried to drink as much water as they could. I think they had to drink well over a gallon in 10 minutes and then see how long it would, who would give up and go to the bathroom first. Sounded like a fun sort of silly competition, but one of the participants actually got this hyponatremia and either got a lot of damage or died. It's not a good thing to try to do to your body. My aunt was recently dealing with this when a doctor inadvisedly, mistakenly told her to drink a lot of water because of stuff going on in her kidneys and her blood pressure, and got her landed in the hospital for a bit. So don't do that. If you have too much fluid in your blood, also this is something to think about if you are giving somebody an IV fluids. You have to be careful about how many IV fluids you give somebody in a certain period of time, because too much volume with a normal blood vessel diameter, even if you're not changing vasoconstriction, you can get too high up a blood pressure because you have too much blood. You can also get a high blood pressure in the ways that we've talked about with a normal blood volume, but narrowing of the vessel. But even, just allowing for that capacitance, if you have too much blood volume, you will put more pressure on the walls. Respiratory pump is going to be sort of a suction-based mechanism that happens when you inhale. So when you inhale, you're opening up that thoracic cavity, and you're doing it to bring air into the lungs. And we're going to talk all about that just in the next lecture as we talk about respiration. But the heart resides in that thoracic cavity as well. And so as you inhale, you decrease the pressure in the entire thoracic cavity. So you'll actually sort of suction the heart open like a balloon in a vacuum. And that's going to lower the pressure in the heart, and it's going to help suck blood back into. So going from higher pressure in the venous system to lower pressure in the heart, blood will flow into the heart. And then when you exhale, you put more pressure on the heart, and that helps get blood out of the heart. So we're going to do a breathing lab here in a week or so, depending on which lab you're doing around all the holidays. And we're going to do some exercising. And you're going to see that as you change what you're asking of your respiratory system as you exercise, you're also going to change your pulse pressure. And that's going to be a proxy for what's happening with this respiratory pump in the vascular system. And you can see laying down is, obviously a very sort of thin pencil sketch drawing, but I like it. When you're laying down and you're at equal gravity across, head and body and feet, when you do this respiratory pump, you do deep belly breathing when you sleep, and you help increase that venous return back to the heart. And this part of the respiratory pump is one of the reasons we think sleep is so beneficial to health. That the more you sleep and the more you do this respiratory pump while you sleep, the more you pull venous blood back to the heart. And the more you pull venous blood back to the heart, the more you pull interstitial fluid out of the tissues and refresh it. And the more you do that, the more you can get rid of those toxins in the tissues, the more you can refresh that fluid with good stuff and pull out the bad, and the easier it is for cells to be healthy. So another reason to get lots of good, deep REM sleep with lots of deep, good belly breathing. All right, and the last thing is our muscular pump. This is why exercise is important. As you constrict muscles, particularly in your lower limbs, but it also helps with your arms, you are going to push on the blood that's in the veins running between those muscles. And as you do it, you help push it back towards the heart. Now, gravity is going to immediately pull it back down. And the way that you don't get lots of pooling in the blood in your feet is that you have semilunar valves in only your veins. So semilunar valves in your veins are going to be pushed open when you put pressure on that blood. And then as the blood tries to run back because of gravity, it will fill those cups, seal the semilunars, and prevent it from going back down. So it's sort of this elevator that raises the blood up a little bit at a time through the legs and gets it back to the heart. So it's these one-way semilunar valves enforce this one-way flow. And it's better the more you exercise, because the more you exercise, the more you push on that blood to get it up that elevator. I want to actually skip real quick to varicose veins, because when those valves function well, that elevator works well. When they don't function well, when they get older usually, or when you have put a lot of pressure on them through a lot of leg crossing, which I am super guilty of because I find it comfortable, you're going to damage the semilunar valves and you're going to get backflow. And then because there's a lot of capacitance in those vessels, you can kind of damage the elastin in there, and you can get these pooling areas where blood is going to pool. So veins become dilated, the valves get leaky, and then you're going to get pooling of the venous blood. And it's particularly visible in those capillary beds and small venules that feed the skin. And so you can see it through the skin. And this is what varicose veins is. And about 15% of adults have them, mostly in the lower limbs. And again, one of those things that gets more accentuated with age, because everything gets a little bit less flexible with age. Okay, let's go back up. The mechanisms of venous return are shown in this video by Alia. Alila, and I really like their videos. I'm going to go ahead and play it here real quickly. But I encourage you, if you need to go find videos on YouTube to kind of help put things together, this is a good company that I recommend. I like what they do. They're not always 100% complete with what your book wants you to know and what I want you to know, but they are 95% complete most of the time. So let's go ahead and take a look at this.
Venous return is the flow of blood from the periphery back to the heart's right atrium. Venous return is important because the more blood returns to the heart, the more blood can be pumped out. In other words, venous return is the major determinant of cardiac output. Venous return is achieved by several mechanisms. Pressure gradient. The difference between venous pressure and right atrial pressure is the major force driving peripheral blood back to the heart. In fact, venous return can be determined as the venous pressure gradient divided by venous resistance. Factors that increase venous pressure or decrease right atrial pressure facilitate venous return. In principle, constriction of veins blocks blood flow, increases venous resistance, and reduces venous return. However, when blood vessels throughout the body are constricted, such as during sympathetic activation, the increased resistance causes blood pressure to rise, and this eventually overrides the increase in venous resistance. As a result, venous return increases. Skeletal muscle pump. Veins in the arms and legs are surrounded by skeletal muscles. They also have one-way valves in their walls that only open for upward flow. During everyday activities, such as walking, the muscles contract and squeeze blood in the veins upward toward the heart. The one-way valves prevent blood from flowing down again when the muscles relax. This is one of mechanisms by which physical exercise increases cardiac output to meet the body's needs. Gravity. In an upright position, venous blood from the head and neck flows downhill to the heart simply by gravity. Blood from the lower body and limbs, on the other hand, has to overcome gravity to return to the heart. People who stand or sit still for extended periods of time may suffer from venous blood pooling in the legs. This happens when venous pressure is not sufficient to override gravity, and venous return is reduced. Because the heart cannot pump more blood than it receives, cardiac output may decrease, sometimes to a dangerous level, and the person may faint. One can prevent this from happening by activating the skeletal muscle pump, either by keeping the legs moving or by tensing leg muscles periodically. Breathing or respiratory pump. During inspiration, the diaphragm moves down, expanding the thoracic cavity, resulting in a decreased intrathoracic pressure and a subsequent expansion of the lungs. Part of this change in pressure is transmitted across the walls of the heart, lowering right atrial pressure and thus facilitating venous return. At the same time, the descent of the diaphragm also causes an increase in abdominal pressure. As the inferior vena cava passes through both abdominal and thoracic cavities, an increase in abdominal pressure together with a decrease in thoracic pressure squeeze the blood upward toward the heart. Increasing the rate and depth of breathing is another way the body raises cardiac output during physical exercise.
Okay, so that walked through those main mechanisms in a way that kind of puts it all together. And I love the animations that really help demonstrate all of these phenomena that we're talking about. And then your book has, again, one of their famous flow charts that puts all of these together. Sympathetic activity to the veins, increased blood volume, increased skeletal muscle pump, increased inspiration movements can all increase venous pressure. I talked about blood volume as being like too much, but this is also one of the reasons why having enough blood volume, by having enough hydration, is good for health. So you can see this, like, I have a friend who's an internist who, like most of the internists I know, he said, I wish I could prescribe tennis shoes. Most of the internists I know, or any of your doctors when you go to them, will say, drink fluids, get enough sleep, get exercise, and then probably eat healthy. But you can see that 3 of those are all right here, right? Sleep, exercise, fluids will all help with venous pressure, helps with venous return. That's going to give you more end diastolic volume, which is going to have more atrial pressure, more end diastolic volume. So we feed that back into our last lecture. When we have more end diastolic ventricular volume, we're going to have a bigger stroke volume. And in return, we have a better cardiac output, which can help us reduce our heart rate, which can make for more efficient and effective pumping that's less hard on the heart. Okay. Okay, so now we're going to back up and put this all together. So integrative regulation of systemic arterial pressure. All right, so we have talked about all of these components. Now let's put them together in one big picture as to how this regulates blood pressure. So we were just here, sympathetic activity to nerves and veins, blood volume, skeletal muscle pump, inspiratory movements, all increase venous pressure, which increases venous return, which increases atrial pressure, which increases end diastolic ventricular volume, which can increase stroke volume. We also know from the last lecture that plasma epinephrine and the norepi that's released from the sympathetic nerves onto the surface of the cardiac muscle, on the ventricles in particular, is going to activate stronger contractions of the cardiac muscle, which is going to improve stroke volume. You're going to get a bigger ejection fraction when you do that. So bringing more blood back with each beat and then making that contraction harder is going to increase stroke volume. That same sympathetic activity also affects the SA node to increase heart rate. Whereas if we decrease parasympathetic activity, we can increase heart rate. So again, gas and brake. Sympathetic is gas, parasympathetic is brake. We're lifting the brake as we're pushing on the gas. Both of those are going to lead to increased heart rate. And an increased heart rate plus an increased stroke volume is going to greatly increase your cardiac output. That's going to affect your mean arterial pressure. More cardiac output, more mean arterial pressure. Now, on the other side of things is the vascular resistance side. Okay, so our local controls, we know we have vasoconstrictors, the myogenic response, which is going to help with blood pressure. The vasodilators are all those things we talked about with flow autoregulation and active hyperemia. This is also flow autoregulation, right? Everything in this list that's something we've already talked about is fair game for the next quiz and the next exam, okay? You should also read about the others because we'll be hitting them later. Neural controls. Sympathetic nerves are going to activate vasoconstriction. Lack thereof is going to let vasodilation happen through the blood pushing open the walls. We've also talked about nitric oxide as a vasodilator from nitric oxide neurons. Hormonal controls. We haven't gotten to these yet. Again, I want you to just sort of know them now. The mechanisms will hit in the next unit. We'll hit those. So epinephrine we've talked about. You should know the mechanism there. Angiotensin 2 and vasopressin are also 2 other hormones that can cause vasoconstriction. And atrial natriuretic peptide is a vasodilator. all of these can change the arteriolar radius. If it is causing vasoconstriction, you're going to up the resistance. And the total peripheral resistance we're talking about across all the blood vessels, how vasoconstricted they are. The more vasoconstricted they are, the more the resistance goes up. And particularly in the arterial system, you have way, way more pressure, so you have way, way more regulation. One other thing we talked about at the beginning of these two lectures on vessels was hematocrit. So blood, remember I mentioned blood a bit. If we increase the hematocrit, if we increase the number of cells, particularly red blood cells, we're going to increase the blood viscosity. Thicker blood is harder to move. It gives you more resistance, and you're going to increase the total peripheral resistance. If you're well hydrated, this shouldn't be a huge factor. We deal more with this in a healthy person. But both of those, if we increase the total peripheral resistance, we're increasing the mean arterial pressure. So the combination of mean arterial pressure, the overall what is and mean arterial pressure that's averaged across all the arteries, is your blood pressure, right? So I want you to get in the habit. This is blood pressure, right? This is how we measure blood pressure. This is how we diagnose blood pressure issues. This is how we treat blood pressure, is the mean arterial pressure. This is what we're talking about most of the time. That systolic pressure, that mean arterial pressure across the arteries is the combination of cardiac output from the heart times the total peripheral resistance. And again, these are inversely related to each other, okay? So, and they're both directly related to mean arterial pressure. So if total peripheral resistance goes up, mean arterial pressure goes up. If cardiac output goes up, mean arterial pressure goes up. If they both go up, they both send mean arterial pressure up. But you can also keep mean arterial pressure the same by upping one and not the other. So if total peripheral resistance goes up and cardiac output goes down, that's a way to maintain blood pressure. Got all these different places that you can do it. You can see that there's this huge diversity of targets that your body has to finely tune your blood pressure. And so most of us, under most conditions, can maintain a healthy blood pressure that serves and feeds our tissues appropriately. And we can do it by shifting it here versus there when we need to, either systemically with the autonomic nervous system, or locally when you just activate, maybe you're gaming for a long period of time and you really need to feed the muscles of your hands, but you don't need to feed all of your skeletal muscles because you're not working your legs very much. So it's a beautiful, fairly complex, but highly regulatable system that your body has to keep you healthy. And we usually only see unhealthiness in severe cases of drugs, disorders, or disease, which hopefully when you have this basis, you can then think about when we think about how to treat a patient. I want you to know all of this figure, all of it. I want you to be able to reproduce it from memory. I want you to be able to predict if I change one of these variables for you in an essay type question. I want you to be able to tell me how that changes other things. Okay? So this is definitely one of those that, again, I hope you can understand it logically, but you may need to brute force memorize it. And if I were you, I would draw this out in my own notes, in my own handwriting, in my own words. And then I would quiz myself on a fairly regular basis from now to the exam to see how well and accurately I could reproduce it. Okay? Okay. All right. One of the things that's going to help modify blood pressure and regulate it are sensory receptors called baroreceptors. Baro is pressure. You have a barometer that tells you what the atmospheric pressure is. Baroreceptors are receptors, stretch receptors in the main vessels leading from the heart and particularly to the brain that are going to determine how much blood is coming out of them by how much stretch is there. So the aortic arch has baroreceptors, and the carotid arteries have stretch receptors. You also have them in the wall of the heart. So when arterial pressure goes up, the arterial baroreceptors are going to increase their firing, and then you're going to stimulate a reflex. So more firing leads to more parasympathetic outflow to the heart. So more action potentials in parasympathetic neurons, releasing acetylcholine on a muscarinic receptors, opening potassium channels, increasing that hyperpolarization, increasing the time it takes to get to threshold in between beats, and lowering heart rate. You're also going to lift your foot off the gas, so decrease sympathetic activation to the heart and the arterioles and the veins. So we're going to do less heart rate, less cardiac output through less myocardial activation, so weaker beats, slower beats, and we're also going to vasodilate in a lot of areas so that we can reduce that overall blood pressure that's going to the brain so that you do not put too much blood in the brain. That has to be regulated very tightly all the time. And remember, when we get to a certain level of pressure, flow autoregulation can't handle it anymore. So we have to make sure we're not overcoming that ability of flow autoregulation of the vessels in the brain to compensate for changes in flow. This is one of the reasons why people, when they get a super big fright, often pass out, because you get a super big cardiac output all of a sudden, you get a super effective baroreceptor reflex, and you shut that all down really quickly in opposition, and you get so much shunting of blood to the brain, you actually counteract the ability to get lots of pressure in there, lots of blood flow in there. And again, only about 4 seconds without proper blood flow to the brain, and you pass out. Again, if you want to study in a way that both studies and kind of waste some time, go look at fainting sheep. Helicopters can go over, surprise them, and a whole flock of sheep will faint at the same time. It's kind of cute and sad all at the same time. Okay, so what happens when blood pressure does not regulate itself well? We can have a couple of different types of hypotension. Hypotension is too low of blood pressure. I get this first kind. I get orthostatic hypotension a lot. It's better nowadays that I kind of drink more caffeine. I used to not drink as much caffeine. When you stand up, the blood rushes to your feet. You have a little bit of a delay in getting that vasoconstriction out of the veins. And so for a brief moment, you don't have enough blood pressure to get it to the brain. And I get that sort of like tunnel vision and, oh, I might pass out. Luckily, I never have, but some people do. You can measure this by putting somebody on a table, strapping them down, blood pressure monitoring while they are level with the horizon, and gravity is the same across the body. And then you flip them up real quick and measure the blood pressure as you're flipping them. And if it drops substantially, you're going to have orthostatic hypotension. Acute hypotension can be a sign of circulatory shock. And so it's something, acute means short amount of time, and you don't have enough blood flow to meet the tissue needs. And we're going to talk about a couple different ways you can get acute hypotension. So circulatory shock can happen when you have acute hypotension. So a couple of different ways you can get circulatory shock. Hypovolemic, not enough blood volume. So this can happen because you're hemorrhaging, or you've had severe vomiting, or you've had severe diarrhea, or it happens in excessive burns when our integumentary barrier is not there anymore and we're losing lots of fluids across the very damaged skin. So you're going to get a weak pulse, and your heart rate is going to increase because the cardiac output is going down because stroke volume is going down. Stroke volume is going down because end diastolic volume is going down. That's going down because venous return has gone down. So you compensate to try to keep the cardiac output the same by having a super fast but shallow heartbeat. It's shallow because we're not getting enough stretch. So Frank Starling is not giving us a very strong beat. So fast, shallow beating to try to compensate. And you have to replace those fluids fairly quickly to be able to maintain blood flow. Otherwise, cardiac output is going to decrease despite the heart's best efforts. So that's why people are going to be transfused in an emergency situation. Cardiogenic shock is when the heart can't beat well enough. And you find this in end-stage heart failure or heart attack, myocardial infarction, that's heart attack. Both of those can lead to cardiogenic shock. So for whatever reason, the heart cannot sustain adequate circulation, and myocardial infarction, like I said, or sometimes you have valve damage, sometimes you have a septum problem in here, you're not getting a strong enough beat out of there. So sympathetic overactivity, again, is going to increase the heart rate, and you're going to vasoconstrict to try to maintain the blood pressure, and the heart just can't keep up. So despite the normal or high blood pressure, you're going to get a lot of edema, and you're going to have poorly perfused. Perfusion is the amount of blood that flows through a capillary bed. So poor perfusion, you don't get enough blood to the tissues, and you can get a lot of damage. Vascular shock is when the blood vessels are not doing their appropriate thing. So you can get extreme vasodilation. So before you have the appropriate amount of blood pressure feeding all of the different tissues well. When you have vascular shock, you get extreme vasodilation in a lot of areas all at the same time, and consequently, you don't get enough blood pressure to the brain and the heart and a lot of the tissues. So you can get this with septic shock or neurogenic shock. So damage to the brain or the nerves to where we're not sending out enough sympathetic stimulation, or septic shock where you've got some sort of problem with a disease state that's leading to extreme vasodilation in the tissues, which leads to poor blood pressure. Our dog actually had this vascular shock when we were treating him for heartworms. He came to us with heartworms when we adopted him. He had some pretty bad heartworms. We had to take him through 2 rounds of ivermectin, which kills heartworms. And the second time around, they can have an inflammatory response because they've already experienced the first round of treatment. And the inflammatory response can lead to extreme vasodilation, which can lead to vascular shock. My husband was right there, thankfully, saw our dog about to pass out, took him to the emergency vet. They pumped him full of a bunch of steroids, kept him overnight, kept him on fluids, and he was fine. But if we wouldn't have been there, he might not have been fine. Okay, here your book gives you a whole effect of hemorrhage on the mean arterial blood pressure. And I'm going to let you work on this as an assignment outside of class, not for points, but again, hint, hint, you should know it. You should know it. You should know it well. You should understand that this is a feedback loop, where to begin, what's happening, what the body is doing to try to compensate for hemorrhage. Okay, so you're starting here with blood loss and how it is affecting arterial pressure and the baroreceptors, and then what your body does to compensate to try to keep your blood pressure from going too low and losing and damaging tissues. Okay, last thing is hypertension, when our blood pressure is too high. Hypertension is usually a chronically elevated state. You raise your blood pressure when you exercise, and you can sustain elevated blood pressure in a lot of your tissues for a limited amount of time. But if we keep it going constantly, all the time, it is referred to as a silent killer, because a lot of times you don't know that you've been doing damage for years until it's already too late. So prolonged hypertension can cause heart failure, renal failure, stroke, and vascular disease because literally the walls of those endothelial cells of your capillaries get too leaky, and you'll get compensation for damage with creating fibrotic tissue in there, and then your vessels don't flex as well, they don't rebound as well. It gets harder and harder to regulate your blood pressure the more damage you do to them. And so eventually they get leaky and the tissues suffer the effects of not being able to properly regulate the blood pressure. So essential hypertension is what most people have. So essential is just sort of the common term for common hypertension. Diets high in sodium and cholesterol often lead to essential hypertension. Obesity is a factor. Being older is a factor. Males tend to have more hypertension than females do. If you have a background of hypertension, which I do, you're more prone to it. It's interesting. Dad's whole side of the family has hypertension. Mom's side of the family, super low blood pressure. Which one will I get when I turn 60? It's a mystery. We'll see. But I'm glad I at least know what my family history is so I can be thinking about it, which means I should probably take a lot more salt out of my diet. And I don't right now. Stress. This is another one where I'm really bad. Smoking. Luckily, I've never done this, and you shouldn't smoke because it's really bad for your blood vessels, along with all the other ways it's bad. Chronic stress also. Lots of vasoconstriction can lead to blood vessel damage if you're doing it all the time. One of the reasons why we should get out more, take more breaks, try to keep that stress level as low as possible. Unfortunately, there's no cure for essential hypertension. So once the damage accumulates, it's really hard to reverse it. So the best thing to do is prevent it. So all of the things that you can change about your environmental situation, you should do. I should do. Let's talk to each other. Let's hold each other accountable. With reducing stress, changing your diet, trying to keep that blood, that body fat appropriate for your genetic background, as we've talked about before, and not letting it get too out of hand. Doing exercise, which can help all of these sorts of things. Those are the places that your doctor is going to start, or you can start if you know you have a history of it. If those are still not managing it well enough, we can do medication, which is going to be diuretics to help keep that blood volume low, and beta blockers, which will help increase vasodilation in a lot of places. And with that, most hypertension can be managed fairly well. A lot of doctors are starting treatment even sooner, and they're getting you as a patient who's maybe pre-hypertensive if your systolic is consistently between about 120 and 130. Most doctors nowadays prefer it under 120 consistently. And even though it's considered hypertensive if you're over 140, they're kind of considering you pre-hypertensive if you're creeping up and typically above 120 in your systolic blood pressure. Okay, that is it for our cardiovascular chapter. And again, in those later sections, please follow the notes and know things that are in the notes. Go to the book for the things that are in the notes and know that well. But the things that I haven't covered, you can skip over because I'm not going to be testing you on it. Okay, if you have any questions, let me know. I hope you have a wonderful spring break, and I will see you next Monday or Tuesday.